there, my name is Jennifer Staggs, and I'm a PGY1 pharmacy resident here at OSU Medical Center. My QI project looked at how we are managing acute pain in hospitalized patients who were established on buprenorphine prior to admission. Given buprenorphine's unique pharmacodynamic properties, specifically its high binding affinity and slow dissociation from the mu opioid receptors, providers can really find a challenge in managing acute pain in these patients. Some providers choose to continue the patient's buprenorphine and use both non-opioid adjunctive medications as well as some higher doses of opioids for breakthrough pain, while other providers may be tempted to stop the patient's buprenorphine while they're hospitalized and being treated for acute pain. In this study, we looked at 6 months worth of adult patients admitted to the hospital with a prescription for sublingual buprenorphine prior to admission. We identified 26 patients who met our inclusion criteria and stratified them into 3 groups. Group 1 resumed their home buprenorphine on day 1 of hospitalization. Group 2 resumed buprenorphine on day 2 of hospitalization, and Group 3 did not resume buprenorphine while in the hospital. About half of our patients were continued on buprenorphine therapy while they were in the hospital. We found that patients who were continued on buprenorphine throughout their hospitalization required much lower amounts of other opioids and adjunctive pain medications than those who did not resume buprenorphine in the hospital. Patients in Group 1 had a 92.6% lower average daily MME of non-buprenorphine opioids than patients in Group 3. We also found that our providers do a very, very good job of utilizing multimodal pain management, with 73% of our included patients receiving multimodal therapies. The reported pain scores were fairly high among all the groups. However, pain scores were not consistently documented in the chart. Patients who received higher amounts of opioids often had more pain scores documented than those who remained on buprenorphine and did not require as many additional opioid doses. Additionally, higher pain scores may be expected since chronic pain was indicated more commonly in the buprenorphine continuation groups, and withdrawal syndrome may explain the persistently high pain scores in the non-continuation group. So this study demonstrates the importance of continuing buprenorphine therapy in hospitalized patients. Moving forward, we would propose standard buprenorphine continuation protocols be considered, when appropriate, to provide better continuity of care and prevent withdrawal symptoms in hospitalized patients. We would also recommend implementing a more standardized approach to pain scale assessment and documentation. Thank you very much.